Okay, well, I think we're happy to take questions. Will you be happy? Yes. I just say it and you don't feel well saying, no, no, I'm not. Okay, yes. Wait a second for the mic to...
My name is Holm. I would like to ask Professor Holm, would you elaborate on what is precision medicine? Is it selecting the best derivative in a family of medicines, like statins, for which persons? Or do you mean by like preparing antibodies for patients' cancer? This is one question. The second one, if I may it, is you look for precision medicine because the standard medicine didn't work. So this is could be considered as the control.
Well, I think precision medicine isn't anything. It is a vision. It is something we are told that in the future this will be possible. And at its most, sort of the most visionary part of the vision, and is that in the future we'll be able to tell, based on our knowledge about you and all your different ohms and your environment and your lifestyle, for the particular condition you have, this is the best treatment. So, and that sort of brings me to the second question. No, at the moment in cancer, precision medicine is often about, because it's still experimental, it is about the patient who has run out of treatment options. But that is not the vision. The vision is that this is what we do initially, long before it, and if we do it right, you won't run out of treatment options because, and anyway, we have given you, if, on the premise of the vision, we have already given you the best possible treatment. So any subsequent options you might get are definitely going to be worse.
Yes, Nadav, Professor Davidovich.
Is it open? Yeah. Thanks for the fascinating panel. I'm coming here from the Health Basket Committee. Sagit is there with me. Tomorrow, Professor Dina Ben Yehuda, the chair of the committee, will be here. So we were exchanging WhatsApp that we need to send all the committee to hear the failed system of our current regime of medical research. I just wonder, this is not the topic of your panel, but it was not even mentioned. What about prevention? What about the paradox of prevention? And why we're always just investing most of the money in downstream solution and not upstream? Again, I know it's not the topic of the panel, but Yechiel, when you were at the end, and I thought that you present the future of medicine is less and more maybe public health and prevention, with all the problems that we have there. But I was curious that it was not even mentioned. And of course, there you have very different challenges in terms of how you do evaluation of different interventions.
Well, I think I said it, that we need to be covered. I said explicitly more direction of public health. But you have a methodological issue with public health because we need to know what we prevent. So in a way, public health depends on disease for research to understand what you prevent. So there are things that you know you can affect. For example, don't smoke, try not to be obese, you reduce your risk of cancer. But whether any of these dietary recommendations given by this personalization of care has to do with prevention of cancer or neurodegenerative diseases, there's research maybe, and we need to manipulate the microbiome, is something that is difficult to tell unless you also follow the disease. Otherwise, you miss the capacity to prevent these things. You only prevent the things you know you can prevent. But certainly, you're right. Public health and prevention should get a top priority in any healthcare planning. But patients, although that come, we are discussing how to take care of victims of road accidents. So certainly not to get into accident and how to improve road safety is key. But we are now on that stage.
I'll say a couple words really quickly. I did actually mention prevention, vitamin D, just joking. You know, I think in the section of my talk where I talked about sort of the agnostology of, you know, drug development, there's a lot to unpack there, but it's clear that, you know, we designed this apparatus for evolving evidence that works really, really well in a particular niche, to mix metaphors. And it doesn't work really well in prevention. So, you know, COVID, I think, illustrated really well where research works really, really well and where it doesn't. When it comes to vaccine development, we have a pretty impressive system. It's, you know, jaw-dropping. When it comes to establishing the efficacy of masks or social distancing, what a freaking debacle. No, like practically no cluster randomized trials run. We had 2 or 3 years to do it. Well, that's because we've designed a research system that is, you know, has practically no purchase on those crucial kinds of questions. And if we want to answer those crucial kinds of questions, we really need to kind of rethink the apparatus that we're using to evolve evidence.
Yes, Professor Moreno.
University of Pennsylvania. So, Professor Barlan, you made me think about a couple of times when I've been on data monitoring committees, and the only person we really wanted to hear from was the biostatistician. There was no conversation after that. Whatever that person said was the way we went. 3 great talks, by the way. Jonathan, I love the idea of deprescription. Who's going to pay for that? I'm going to write to my friends, the CMO of a big medical company and big pharma, and tell them we need to invest in deprescription. Okay, good luck. On the landscape business with IRBs, REBs, RECs, I don't know that in the US an IRB would be allowed to do that. We are so constrained. Chris probably knows more about this than I do. We're so constrained by just looking at the current protocol, right? So landscape, forget about it. Indeed, one of the things I don't like about non-local IRBs, if I can say this, which are now the big thing, is when I was an IRB in New York in an inner city medical school in the early 90s, and a guy from one of our affiliated hospitals would come every month with another slash and burn protocol for breast cancer. And they were all pharma studies. And we knew that he did not have the staffing to follow his patients properly. But we couldn't stop it. And indeed, that guy got the death penalty from the FDA a couple of years later. Right? So we're very constrained in terms of the regulations, in terms of what IRBs can do.
Can I just respond really quickly? So yeah, I mean, I often think of George Orwell's essay, Shooting of an Elephant, when I think about what IRBs do. But you know, leaving that aside, a couple remarks. First of all, in Canada, there is a requirement honored in the breach that if you're doing a clinical trial, it needs to be preceded by a systematic review. So IRB is certainly capable of, at least in the Canadian regime, of seeing whether there's a line in there that says, here's a systematic review and here's the estimate. And this is why we want to do a study. The second point I would make is that I've heard this, you know, what you said from IRB people, and it may genuinely, you know, sometimes I hear these things and I think, boy, maybe I'm like super clueless and I'm just missing something that's really obvious. Or maybe not, I don't know. Like, I'm trying to figure it out. I don't understand. IRBs are required by the common rule in the States to establish a favorable risk-benefit balance where that's understood in terms of the amount of risk being justified by the amount of benefit to a patient, if any, plus the value of the knowledge that's generated. Now, scientifically, how would you do that? Well, you would have to look at the prior evidence to see whether this study is a shot in the dark or whether it's already resolving a question that's already been resolved. So if you're told that you have to do a risk-benefit balance for an enterprise where the benefit is answering a scientific question, you would, by definition, need to look at the quality and strength of science behind it. Now, I get that IRBs are not resourced to do this, which is an interesting observation. Why create an institution and give it a mandate without the resource to do it? How is it that that, for decades, continues to be something that we acquiesce to and we tolerate? We can leave that aside. I do think that there are some other remedies that people have talked about that would perhaps perpetuate the IRB disengagement with this issue while addressing the problem. For example, there are many people who argue that there ought to be some sort of a merit review that is joined with IRB review. I know at Stanford, for example, there are various kinds of merit review systems that are being established, through the metrics program there, that are aimed at trying to sort of screen studies to make sure that they have a sufficient merit to command recruitment of patients. And I think that probably better use of committees that are calibrated to the question of scientific merit would be really, really helpful. Anyway, just a quick thought.
I wish to be stronger here. We have this style of talk in research ethics about the dark Middle Ages of the Tuskegee area and the enlightened period of IRBs. But I am certain that at least a good regulatory mechanism that follow research, not just approve research, establish, we are still in part of dark ages. And I myself know from cases that come to me, I review files for malpractice claims, lack of reporting of complications. You don't know whether research or not, lack of monitoring. There are certainly in Israel, there is a very weak structure for monitoring the research, monitoring compliance, monitoring the welfare of patients. There is also international issue of regulation. I give you one example of a person that got melanoma. He was treated with experimental immune therapy. The army sent him. He was an officer. I saw this file as an expert when he claimed for veterans' rights because the army sent him for treatment. And the clinical trial he participated in was shut down early for safety reasons. He himself got insulin-dependent diabetes at an age that the risk to get it naturally is 1 to 20,000, and you want to check the data. What were the safety reasons? Were other patients, you cannot get this data. It's not clear by Israeli law whether the CRT, the file of the medical experiment, it falls under the Patient Rights Act that you need to keep for 100 years. By research ethics, 7 years. When these things were brought to court, drug companies settle fast. They don't want anybody to decide. So it's one example that is good. I mean, when patients do not sign in for research, it's not just to say, well, they are not with a spirit of solidarity, and I encourage research. I'm not trying to convey any anarchistic message, but we have problems to deal with. It's not that there was history that was dark and now we are all doing things well, and why everybody else not join us. There are issues in monitoring research in terms of safety, certainly.